I'm Dr. Stephen Paget, Chief of Rheumatology at Hospital for Special Surgery, and it's a pleasure today to introduce Dr. Virginia Steen, a tenured professor at Georgetown University, who's an acknowledged international expert in scleroderma. Today she'll describe the clinical and pathogenetic mechanisms related to scleroderma. Dr. Steen, scleroderma is a disease that seems to be improving with regard to its outcome, probably because medical care is better and patients are being referred to the right doctors. But have we improved our concept about what causes the disease?
Unfortunately, we have not come up with a cause. There are lots of people that are working from a pathogenesis in the cellular level, and they found lots of things that happen. But what the primary effect is that causes all the problems and what the initiating factor is, we still don't know.
If you had to choose the optimal therapeutic modality, what would you aim it at this moment?
I think it has to be aimed at the immunological effects that are stimulating the process to go on, whether it's the TGF-beta or whether there's other factors, but we somehow or another have to turn off this whole system. But the problem is there's so many things that are turning it on that it's hard to turn it off.
Of those problems that have improved over time, what are the therapeutic modalities that have best helped patients with scleroderma?
I think we've made the most progress with renal crisis and the use of angiotensin-converting enzyme inhibitors. That's really totally changed the face of what renal crisis is. At this point, we're working hard on the interstitial fibrosis and have medications that at least can affect this. Whether it's going to end up totally changing it, it's hard to tell because we don't get patients early enough. Most often they're being treated later in their course, so we need to treat them earlier and hope that that will prevent it. And hopefully the development of the new medications for the treatment of pulmonary hypertension, which is at this point the most deadly complication in particularly limited scleroderma, that at least those patients will have improvement in their life activity and hopefully lifespan.
Gastrointestinal disease is a very annoying thing, from basically up to the top of the esophagus all the way down to the rectum. What have been used more recently to help people in that area?
Yeah, that's probably the area that's had the least exciting things. We've benefited a lot from the proton pump inhibitors, but and people with the reflux and all of that have been, really helped by that. But the motility problem has, if anything, sort of gone backward with the withdrawal of propulsate or cisapride from the community, and so a lot of patients that need a motility drug, we don't really have anything for. So that's been a real tough one to deal with.
Do you think the prophylactic use of ACE inhibitors is appropriate?
No, I don't think there's any data to support that giving someone an ACE inhibitor will prevent them from developing. There are suggestions that patients that have been treated prophylactically still get renal crisis, and it's probably because the system, the renin-angiotensin system, gets turned on and overcomes the small amount of ACE inhibitor that you have on board at that point, and it doesn't matter.
What would you say is the most important advance in the last 10 or 20 years in scleroderma? Both in conceptualization of the disease or its therapy?
Well, certainly in therapy, the ACE inhibitors are I think that's little question that. As far as the conceptual, we've made so many advances from when I started, they didn't even know that the fibroblasts were normal in the last 15, 20 years. So now they know they're normal, what they're doing, and all these cytokines. The gene work's going to be interesting. There's a gene that they've identified that's in a small group of Choctaw Indians that's the same gene that is possibly responsible for the disease in the tight-skinned mouse. So that all is quite exciting, but it hasn't quite gotten there yet.
We've heard a lot about bone marrow transplants. Is that the wave of the future?
Oh boy, I'm afraid that that's the direction that a lot of the connective tissue diseases are going. But ability to choose which patients that you're going to subject to this treatment is not there yet, and they can pick, quote, sick people, but some of those sick people are going to do well and some of them aren't going to do well. It's a real fine line between getting worse and not irreversible, and then when you're so sick and you subject them to this very rigorous treatment, there are a lot of risks to it. So I find it very difficult to find that that's going to be the answer, and there have been recurrences. And whether the differences are because of the ongoing care that they have to have for the transplant, there are a lot of questions to be answered on that.
You have had a broad experience in this disorder over many years. Could you tell the physicians and the patients that you're now talking to what to expect in the future and how the prognosis has changed over time?
Well, the prognosis has improved for both the patients with limited and diffuse scleroderma, somewhere between 40 and 50% between the 1970s and 1980s. And I would hope that the 1990s, when we have a chance to analyze it, that will continue. I think that we're going to benefit from other drugs and development of treatment from other subspecialties to affect our individual organ system problems, and I hope that the scleroderma community is very geared up, both patients and physicians, to look at those drugs that become available, and I think we're going to be able to make a lot more progress as soon as when the TGF-beta drugs become available. We're going to be ready to study them right then and there, and we won't have to take 3 years to get organized or get funding or any of that, as we used to do. It's taken, some of our studies have taken 10 years to get done because they were done on shoestrings. And I'm hopeful that that will be changed a lot.
You've had a particular interest in the use of D-penicillamine in people with rapidly progressive diffuse skin disease. Have you found it helpful in changing the overall prognosis, and in whom do you use it?
Yeah, we've been using penicillamine ever since Dr. Gerald Brodman felt that it was helpful, and I've analyzed it on numerous occasions. And although our data is such that we don't have any control data, and our retrospective data is just people that didn't get the drug, it's not randomized or matched or anything, I find it hard to believe that the data isn't real. There are, for patients with this early diffuse rapidly progressive disease, 2/3 of them will have a 50% improvement in their skin at 2 years. The overall survival is also significantly better in that group of patients that take the penicillamine.
So you think what happens in the skin is a proxy for what's happening viscerally?
Yeah, I have a recent study that took that group of patients and showed that if you look at the first 2 years, if they survive the first 2 years and have improvement in their skin during those 2 years, they have dramatically different survival than those group of patients that had worsening or stable skin during that same 2 years. Now, that doesn't deal with the first 2 years of deaths, but after that, if you have improvement in your disease, you have a much better outcome.
What are your thoughts about the use of relaxin and minocycline in this disorder?
Well, we were very excited about relaxin because of the initial study showing really significant effects and improvement on the skin. But the recent, very large, well-conducted study showed no effect of this drug, and I'm afraid that's gone. The minocycline issue is a bit more controversial. It was based on a small number of patients and a lot of hype, and I don't know of any study that's being done to show.
Thank you very much.
Okay.